The listening part of the occupational English test has 3 parts, and in each part you hear a number of different extracts. At the beginning of the test, you will hear a beep sound. You have time to read the questions before you hear the extracts. You will hear each extract only once. You have to complete your answers as you listen. At the end of each test, you will be given 2 minutes to check your answers. Part A. In this part of the test, you will hear 2 distinct extracts. In each extract, a healthcare professional is talking to a patient. For questions 1 to 24, complete the notes with the information you hear. Now look at the notes for Extract 1. Extract 1, questions 1 through 12. You hear a physician talking to a new patient called Bernardito. For questions 1 to 12, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes. Good afternoon, doctor. I am Bernardito.
Good afternoon. May I know what your problem is?
I am having a severe stomach ache.
What do you feel?
I have heartburn and severe pain, doctor.
Since when have you been feeling this acidity and pain?
For the past 2 months, my stomach hurts after every meal. The pain persists even during nights.
Have you eaten any heavy food or something different in the last 2 months?
No, actually.
How severe is the pain? Let's say on a scale of 1 to 10, how would you scale the severity of the pain?
Well, I can say between 4 to 5.
Is the pain continuous?
No, it hurts only fleetingly.
Do you feel the pain after meals?
Yeah, probably because it hurts every time after I eat.
Is there any kind of food that bothers you much?
Yeah, greasy food.
Oh, I see.
Yes, at home we eat a lot of greasy food.
Where in the abdomen does it hurt? Tell me the exact point. Does the pain shift to your chest, shoulder, back, or across your abdomen?
It hurts in the middle. At times the pain moves across my abdomen.
Besides the pain, you said you have heartburn?
Yes, I feel a kind of sour taste whenever I burp.
Do you feel like this more during the day or in the evenings?
Both. I feel the acidity during the day and at night.
Is it getting worse whenever you lie down?
Yeah, I get an acid-like taste in my mouth.
Besides greasy food, are you getting some irritation in your stomach when you eat any other kind of food, like spicy food?
No, actually, we don't eat spicy food at home.
And tell me, how frequently do you have a bowel movement?
No, it hasn't changed. It's regular.
And tell me, how frequently do you have a bowel movement? And has there been any change in your bowel movements for the past 2 months?
Yes, it has become a little bit softer.
Is there any change in the color?
Yeah, it is greener.
Greener and not darker? Any blood in your bowel movement, or is it darker?
Not darker. And there wasn't any blood in my bowel movement.
Okay, let's first diagnose your abdomen to check from where the pain comes. You said you are feeling pain at the middle part of your abdomen.
Correct.
Does the pain stay there only, or does it move somewhere else?
It usually stays there.
Do you feel acidity and heartburn during the pain?
Yeah, you were right.
Do you have vomiting or nausea?
No, not now.
What did you eat today?
I ate meat and tomato sauce.
Do tomatoes give you any trouble?
Not exactly. I have been eating tomato sauce always.
Do you get any trouble when you have orange juice?
Yeah, at times.
How do you feel then?
I get a strange metallic taste.
You do not feel acidity then?
No?
Now, tell me, what do you do whenever you get stomach aches?
I take Alka-Seltzer at times. That gives me a relief from the pain to some extent.
Yeah, that should help with the relief. Do you take any Maalox, Tums, or Mylanta?
No.
Have you ever taken any medication on a consistent basis, such as Advil, aspirin, or Motrin?
I was taking Tylenol usually.
Okay. As I told you earlier, I'm going to examine your feces to investigate whether you have any kind of parasite. Tell me, do you either come from the tropics or have you ever been traveling to any of the tropical regions or overseas?
Yeah.
Parasites that are found in most of the parts of the world affect the stomach. Besides, I want to check for any occult blood. You have mentioned earlier you haven't seen any changes in your feces, and it's only greener and not darker. Sometimes, if you have a hemorrhage in your stomach, then the digested blood could produce a chemical reaction so that you can have occult blood in your feces. In such cases, we don't see the red color or dark color of the digested blood. Therefore, a diagnosis is essential. Moreover, I would like to diagnose your upper gastrointestinal system through x-rays and contrast. You will be given a thick substance to drink, and then the radiologist would observe how your liver digests the substance and observe your stomach movements. Because I think that your pain comes from your gallbladder and not from your stomach, I will have to do this kind of diagnosis. After a thorough investigation, let me decide whether I should take the x-ray test or an ultrasonic study of your gallbladder. Do not eat any greasy food for now, and also do not have your dinner just before going to bed, because it could produce more acidity. Eat normal food and nothing spicy. I shall get back to you as I receive your medical reports from our lab. Anything else?
With so many medical tests, I'm afraid I have an ulcer.
I too have that kind of doubt. That is why I have suggested all these tests. I need to explain to you that an ulcer or other irritations in your upper intestines cannot be detected by x-ray at times. If the pain continues after having some antibiotics, you may have to go for an endoscopy. An endoscopy is a medical investigation in which a tube will be inserted through your mouth or nose, and then the specialist will observe your stomach, from the small intestines to the large one, and your gullet. Do you need any clarification?
No, doctor, thank you.
Good. Let us meet next week. Goodbye.
Extract 2, questions 13 to 24. You hear an optometrist talking to a patient called Dominica. For questions 13 to 24, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes. Good morning, Mrs. Dominica. How can I help you?
Good morning, sir.
Can you show me your registration card? Or should I search your details through your mobile number?
I think that would be better. My mobile number is 078-823-78979.
Okay, I've tracked your record. You last visited on the 27th of August, 2016.
That's correct.
Just pay the doctor's consultation fee here.
Sure, this is my card.
Please take your seat and feel comfortable. Should I help you with water, newspapers, etc.?
Thank you. Hello, doctor.
Hello, Mrs. Dominica. So how can I help you?
I just came for a regular checkup for a suspected case of glaucoma. 18 months ago, Dr. Gonzalez advised me to undergo a precautionary checkup once a year, knowing my family history of glaucoma and after examining my eye. He told me that my optic nerve is thicker than the usual.
That's probably the reason you were asked to undergo a precautionary checkup every year. You can have the visual field analysis and OCT today. And once you receive the 2 test reports, let's meet again in the afternoon.
Okay, doctor.
Yes, Mrs. Dominica?
Hello, sir. The doctor advised me for these 2 tests.
Okay. The 2 tests would cost you £200, and you'll get the test reports in around 3 hours. Is that okay with you?
That's fine.
Please be seated here. Someone will call you back for the first checkup in just a few minutes.
Thank you, sir.
Hello, Mrs. Dominica. I hope you had a good experience going through those 2 tests.
Yes, it was. And since I've taken the test before, I know what to expect.
Your test reports are perfectly okay. Since these reports haven't shown anything suspicious in so many years, I think you can now take these tests once in 2 years and not every year.
Okay.
Well, that puts the glaucoma thing to rest. Do you work on the laptop for long hours?
Yes, doctor. Being the chief accountant, I have to work all day on computers.
If your eyes become tiresome very quickly, I will recommend an eye drop that can be applied thrice a day. Generally, the eyes become tiresome when we continuously look at the computer screen without blinking for long. In such a case, this eye drop would lubricate the eyes.
Actually, I see a few black, thin, wavy structures floating before my eyes that don't disappear even after closing my eyes. What are they? Will it cause any serious problems to my eyesight?
Not actually, they're called floaters. As we age, floaters develop to different extents. They're not harmful. Actually, floaters may appear like gray or black specks, cobwebs, or strings that float during eye movements and appear to break away when you look at them directly. Generally, most eye floaters are caused due to age-related changes that occur as the jelly-like substance called vitreous inside the eye becomes more liquid.
Are they very serious, doctor?
Getting a new floater or the appearance of light flashes are the signs that the vitreous gel is pulling on the retina that can lead to a retinal detachment, a serious condition that can be treated with a surgery.
Can anything be done about the floaters in the eye?
Rarely, floaters may become very dense and plentiful and affect the eyesight. In such cases, a surgical procedure called vitrectomy may be suggested to remove floaters from the vitreous. A vitrectomy is performed to remove the vitreous gel along with the floating debris from the eye.
How can I get rid of floaters, doctor?
Normally, most of the eye floaters don't require treatment. It requires some patience and caution to get rid of them over time. When floaters become so large or numerous, they can impair the vision.
What kind of vitamins will be effective to treat floaters?
Although our government doesn't approve the Food and Drug Administration for treating floaters, there is anecdotal evidence that intake of vitamins can improve the eyesight and reduce the dominance of floaters. You can take a vitamin A supplement that includes selenium, magnesium, and DHA, as these nutrients help to treat floaters.
Can you suggest to me some foods that will be effective to control my eye floaters?
Well, you can indulge leafy green vegetables like spinach, kale, and collards in your meals. You can also have salmon, tuna, and other oily fish, eggs, nuts, beans, and non-meat protein sources. Citrus fruits or juices such as orange, oysters, and pork in your diet.
Thank you, doctor. Thanks for your time.
You're welcome.
In this part of the test, you will hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare environment. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You will have time to read each question before you listen to the audio. Complete the answers as you listen to the audio. Now, look at the question 25. You hear a discussion about common types of neuropathic pain. Now, read the question.
Hello, Doctor. What are the common types of neuropathic pain?
Well, while there are countless types of neuropathic pain, some of the prominent types include carpal tunnel syndrome. Is caused by nerve compression in the wrists and causes pain in the wrist, thumb, and fingers. Central pain syndrome can occur after nervous system damage, such as a stroke. Degenerative disc disease, one may feel neuropathic back pain if it causes damage to the nerves entering or exiting the spine. Diabetic neuropathy causes stabbing pain in the hands and feet of some diabetic patients. Phantom limb pain can occur in some patients after a limb is amputated. Postherpetic neuralgia is brought on by an outbreak of shingles and persists after the condition has cleared. Pudendal neuralgia is a type of pelvic pain caused by compression of the pudendal nerve. Sciatica is caused by compression or irritation of the sciatic nerve and often results in shooting pain that radiates down the back of the leg. Trigeminal neuralgia is characterized by shooting neck and facial pain. Question 26. You hear a discussion bronchodilators used to treat chronic obstructive pulmonary disease. Now read the question.
Hello, doctor. What are the different types of bronchodilators used to treat chronic obstructive pulmonary disease?
Patients with chronic obstructive pulmonary disease are often prescribed a bronchodilator, a type of medication for relaxing the air passages to help breathe better. Typically, the medications are inhaled through the mouth using a metered dose inhaler, but also come in liquid, pill, injectable or suppository formulations. The three classes of bronchodilators commonly used to treat chronic obstructive pulmonary disease are beta-adrenergic, beta-agonists, anticholinergics, methylxanthines. Beta-adrenergic agonists are a type of medication that binds to specific receptors in the lung called beta-adrenoceptors. By doing so, they block the trigger to bronchial spasms and allow airway passages to open. Beta-agonists can either be short-acting or long-acting, which are delivered either orally or through a metered dose inhaler. Generally, the inhaled method is preferred as it alleviates symptoms faster. Anticholinergic blocks the neurotransmitter acetylcholine in the central and the peripheral nervous system to its receptor in nerve cells and inhibit parasympathetic nerve impulses. Methylxanthines affect not only the airways but stimulate heart rate, force of contraction, and cardiac arrhythmias at high concentrations. Question 27. You hear a discussion about pancreatic neuroendocrine tumors. Now read the question.
Doctor, what are the various types of pancreatic neuroendocrine tumors?
There are different kinds of functional pancreatic neuroendocrine tumors. Gastrinoma usually forms in the head of the pancreas and sometimes forms in the small intestine. Most gastrinomas are malignant. Insulinoma forms in the head, body, or tail of the pancreas. Insulinomas are usually benign. Glucogenoma forms in the tail of the pancreas. Most glucogenomas are malignant. Vipiomas, which make vasoactive intestinal peptide. Somatostatinomas, which make somatostatin. Question 28. You hear a discussion about melasma and different types of melasma. Now read the question.
Hello, doctor. What is melasma and what are the types of melasma?
Well, melasma is a common patchy brown, tan or blue-grey facial skin discoloration, normally seen in women during their reproductive period. It typically appears on the upper lips, upper cheeks, forehead and chin of women of 20 to 50 years of age. There are 4 types of pigmentation patterns are diagnosed in melasma: epidermal, dermal, mixed, and an unnamed type found in dark-complexioned individuals. The epidermal type is characterized by the presence of excess melanin in the superficial layers of skin. Dermal melasma is defined by the presence of melanophages throughout the dermis. The mixed type includes both the dermal and epidermal type. In the 4th type, excess melanocytes are present in the skin of dark-skinned individuals. Question 29. You hear a discussion about possible causes of arthritis. Now read the question.
Hello, doctor. Can you tell me what are the possible causes of arthritis?
Osteoarthritis is associated with cartilage damage. Genetic conditions are thought to play a role in osteoarthritis. Age alone is no longer seen as the cause of osteoarthritis. Rheumatoid arthritis is an autoimmune disease that develops as the immune system malfunctions and attacks the body's own tissues. Gout develops when excessive uric acid accumulates in the body and crystals are deposited in the joints. Reactive arthritis causes joints to become inflamed as a result of an infection that triggers the immune system. Usually, this condition resolves. Question 30. You hear a monologue of a physician on granulomas. Now, read the question. Granulomas are tissue nodules of immune cells that occur in diseases such as sarcoidosis and tuberculosis that can damage many organs. It is the chronic activation of the metabolic sensor mammalian target of rapamycin that is responsible for the granuloma's formation. In sarcoidosis, this mechanism leads to a course that is chronic and difficult to treat. Since mammalian target of rapamycin inhibitors belong to a group of drugs already licensed for clinical use, these findings offer new and quickly testable treatment options.
Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear a healthcare practitioner talking about aspects of their work. For questions 31 to 42, choose answer A, B or C, which you think best fits according to what you hear. Extract 1, questions 31 to 36. You hear dietitian Catherine Weston delivering a presentation on diabulimia. You now have 90 seconds to read questions 31 to 36.
Hello, my name is Catherine Weston and I'm a dietitian with a keen interest in a little-known condition called diabulimia. The name is derived from a mixture of diabetes and bulimia, as it describes the situation where type 1 diabetics develop the behavioral characteristics of the aforementioned eating disorder. As insulin restriction is a significantly more dangerous act than calorie purging, the sooner something can be done about the countless lives being lost because of diabulimia, the better. To put things in context, it is estimated that approximately 400,000 people in the UK are living with T1. Whilst the exact number of people living with diabulimia is unknown, alarmingly up to 40% of sufferers, who are mainly female, aren't taking enough insulin to survive. With that acknowledged, it would be remiss not to mention that those affected are not exclusively women. A recent German study suggests that 11.2% of boys aged 19 and under are intentionally depriving themselves of insulin in a drive to be thin. Yet, despite the widespread reach of this condition, it is not as visible as other similar disorders, such as anorexia or bulimia nervosa. Part of the reason the condition is so low profile is the fact that the condition is not a recognized medical or psychiatric term, but rather it highlights the practice of reducing or eliminating insulin in a bid to lose weight. As diabetes sufferers cannot produce insulin but need it in order to survive, the practice of restricting their intake with the aim of losing weight is incredibly dangerous. Sufferers run incredibly high blood sugars, which has the potential to produce multiple irreversible diabetic complications. This can include neuronal, retinal, and renal damage. The most common symptoms of the disease include irritability, decreased concentration and motivation, and diabetic ketoacidosis, all of which are analogous to diabetes. Rather eerily, by making the decision to cease treatment, sufferers are essentially turning the clock back on their condition. I do a lot of work with Diabetes UK in order to raise awareness of the signs and signals of diabulimia with friends and family of people with insulin-dependent diabetes mellitus. This type of outreach work was sparked by the many case studies of young people whose lives have been claimed by the disease. One such account is of the life of Amara, a 27-year-old who took her life after battling with the disease. Typically of people with the condition, Amara developed an unhealthy preoccupation with food. She also became increasingly uncomfortable taking her daily medication, comparing injecting her insulin to injecting fat into her body. Her sporadic insulin restriction then became a greater feature of her life. The unhealthy obsession with her diet led her to the discovery that despite not lowering her food intake because she had drastically reduced her medication, she was losing weight. The weight loss is a result of the body cells failing to absorb blood sugar, with the consequence of prolonged elevated blood sugar in the individual. This causes the organs to be saturated in glucose. Amara was found dead, having taken her life after a futile years-long struggle with diabetes. Her death highlights the crisis for the medical and diabetic communities, neither of which have the resources or systems of care in place to support such a nuanced disease. In fact, such tragic consequences are so severe and such stories are so tragic that early detection is a governmental priority. NHS England's clinical team have been involved in producing the NICE guidelines on eating disorders, devoting part of the report to managing people suffering from an eating disorder and diabetes concurrently. The guidelines have been distributed nationally in a bid to tackle the illness. Furthermore, the organisation is integrating psychological services with GP practices by placing 3,000 new mental health therapists and surgeries. In addition, other private and charitable organisations are also keen to play their part. A prominent example includes Jacqueline Allen, founder of national charity Diabetics with Eating Disorders. Allen is presently campaigning for the omission of insulin for weight loss purposes to be recognised as a mental illness. The theory is that increasing the condition's visibility, it will become easier to engage multidisciplinary teams, including endocrinologists, mental health professionals and specialists like myself who specialise in the condition, to provide a 360-degree treatment service. Until that is achieved, however, the road to medical and psychological recognition continues.
Now look at Extract 2. Extract 2, questions 37 to 42. You hear a junior doctor called Graham Holder giving a presentation on the subject of hand transplants. You now have 90 seconds to read questions 37 to 42.
Good morning, my name's Graham Holder. I'm a junior doctor here at the hospital. The subject of my presentation today is hand transplants. I'm not a specialist in this area and I have no direct experience of it, but I've always found it fascinating and I'd like to share my interest in it with you. So, first of all, what is a hand transplant and why is it better than prostheses? Well, it's a type of CTA, that's a composite tissue allotransplantation, in which skin, fat, muscle and nerve bone are all transferred from one person to another. To date, it's largely been used to treat patients with both functional and aesthetic deficits that can't be dealt with by conventional methods, but this is changing. The mainstay of treatment for amputated limbs has long been prostheses, but patients often reject them because they only provide limited mobility and function, and they can be uncomfortable. In theory at least, transplanting a complete part should give much better results than even the most advanced prosthetic technology. So, more and more upper limb transplants are being performed around the world every year, and this is largely thanks to new and more powerful immune suppressive drugs. The strategies in use have been derived from the experience of transplanting organs, especially kidneys, and this has also informed the choice of drugs. Slightly higher amounts of immune suppression are used with a potent induction, followed by a low-dose maintenance regime. This regime can be supplemented by short courses of intensive therapy to overcome any episode of acute rejection. The survival rate of both patients and grafts under this regimen outperforms that for all other transplants. That's actually pretty impressive. At least one episode of rejection is recorded in 90% of cases, however, despite the immune suppressive protocol, and this is much higher than with kidney transplants. One reason for this is that hand transplantation represents a visible graft. That means you can make an immediate diagnosis of rejection based on minor changes in skin appearance, even though this has to be confirmed by a biopsy. If patients adhere to the regime, however, rejection is generally reversible. One of the challenges of hand transplantation is to achieve the delicate balance that prevents rejection whilst at the same time protecting patients from the direct toxicity of the medicaments. But this seems to be working, and infection is actually the commonest complication. So, what happens during a hand transplant operation? It's a 6-hour procedure which involves 2 separate surgical teams, one removing the hand from the donor and the other working with the recipient. Bones are joined with titanium plates and screws. As with other bone grafts, they should eventually heal together, but the plates are left in to ensure stability. Surgeons then connect key muscles and tendons before tiny blood vessels are connected using surgical microscopes. 3 major nerves are then attached, followed by large and small veins. Once blood is circulating, the recipient begins to feel the new hand. A recent case attracted a lot of interest in the UK. It was a bilateral transplant for a man who'd lost both hands in an accident at work. Now, bilateral transplants aren't so uncommon, but what made the case particularly noteworthy was the fact that he still had both his thumbs, but not the rest of his hands. So it wasn't a transplant performed at the wrist, as is usually the case, but in the substance of both hands. Nonetheless, immediately afterwards, he managed to gain some movement in his donor hands and has since improved dramatically. Indeed, just 9 months after the procedure, he was able to write a thank you letter to the surgeon. His recovery experience mirrors that of most transplant patients. The incredible thing about him is the speed at which he's gained that functionality. So, what about donors? One of the challenges of hand transplantation is that the hands not only have to fit immunologically, they also have to look right because they're going to be on view, an issue that doesn't arise with internal organs. That makes the job of finding an appropriate donor even harder. In any case, because hand transplantation is rather unusual, people have been slow to donate, and there have been occasions when surgeons had to ask for a donation when somebody's offered other organs, but not specifically the hands, and that's a really difficult thing to negotiate with next of kin at the time of death. The hand transplant program is now established and it's becoming mature. It'd be nice to think that hand transplants could become as routine as kidney transplants. Setting up a donor network is the next goal.
That is the end of Part C.